Hello, everyone, and welcome to A Bit More Complicated, the podcast where you can hear science-based discussions about important topics, issues, and problems in society, and then what we can do to make them better. I'm Manuel Galvan at UNC Chapel Hill.
And I'm Dylan Selterman at Johns Hopkins University. Today, we are again focusing on the topic of healthcare for transgender and gender diverse individuals. We did an episode recently on this topic with Dr. Q McLemore. That's episode 23, so go check that out if you haven't already. And as we emphasized in our earlier episode, we really want to approach this topic with a great deal of thoughtfulness and care. One of the points that Manny made in our discussion with Q is that trans individuals face a lot of obstacles, not just in terms of medicine and healthcare, but in terms of broader societal stigma and discrimination. So our goal here is to shed light on the topic of gender in a way that is respectful and supportive of trans rights. Manny and I are both interested in being good allies for gender diverse folks. That's very important to us. And our guest today is Dr. Erica Anderson. Dr. Anderson is here to talk to us about gender-related professional care and transition for children and adolescents. She is a clinical psychologist with over 30 years of experience working with clients who experience gender dysphoria, including very little kids, teenagers, and adults. She is a faculty member and medical staff member at the UC San Francisco Division of Pediatric Endocrinology. Dr. Anderson is a proud transgender woman herself and brings this personal perspective into her clinical practice and advocacy. Dr. Anderson is not just a clinician, she has also served on the board of WPATH, which is the World Professional Association for Transgender Health, and was also the president of USPATH, which is basically the American version of WPATH. And she is a member of the American Psychological Association committee writing the guidelines for working with trans individuals. Dr. Anderson has appeared on a number of TV shows, podcasts, and other programs, including PBS, Megyn Kelly, 60 Minutes, and Quillette. And she's written for outlets like The Washington Post and Persuasion. Knowing just how important and busy you are, we really appreciate you taking the time to speak with us. Dr. Anderson, thank you for joining us today.
It's my pleasure. At the outset, though, I should correct the intro.
Oh.
I no longer am at UCSF. I'm a free agent now, so. Yeah. And you must have gotten an old bio because the number I usually put in now is 40 years of experience.
Okay. All right. Good. Thank you for those corrections. All right. So I think what we want to do here is dive right into some of the meatier aspects of this topic. And I'll just say right from the outset that I feel personally like I'm in the process of learning about this, and it's very complicated, which is kind of great because it's the theme of our show. But as I was telling Manny earlier, I feel like I don't have a lot of very solidly formed opinions on this topic. I feel genuinely curious to understand on a deeper level. So I want to start out by asking you, Dr. Anderson, straight up, do you perceive a legitimate disagreement or debate or even controversy amongst the experts in this field? So that means, researchers, doctors, practitioners, about the best practices for treating young people with gender dysphoria? And if so, what would be the crux of that disagreement?
Yes, there are some controversies. I've been very direct about it for the last few years. And one of the controversies that I think is very important is that the standards of care recommend a comprehensive individualized assessment for every gender questioning kid. And too much to my chagrin and horror, that's not happening in the way that it should. And so there are some providers, at least in the United States, who have moved into essentially an aggressive pro-medicalization stance where they're giving access to gender questioning kids to medical interventions very quickly without an adequate evaluation, in my opinion.
Thanks for that. So I want to come back to this question of medicalization, but part of the reason that I wanted to ask this first question is because in the mainstream press, some journalists have pointed to what they're characterizing as you are, a legitimate disagreement amongst professionals regarding best practices. and maybe disagreement about where the gaps are in our collective knowledge. But on the other hand, some folks, some very intelligent, very well-meaning folks are saying there is no disagreement whatsoever. There's a strong consensus for the efficacy of these treatments to anybody with gender dysphoria, that the science is settled. And to suggest otherwise is part of fear mongering, concern trolling, right wing anti-trans panic. So, what do you think about this?
Hogwash. The idea that there's no disagreement is patently false. You look at the authorities in Europe, in the UK, Sweden, Finland, France, the Netherlands. They're all observing a far more cautious approach. They're doing evidence-based reviews, and they're pointing up some of the issues that I've been talking about for a number of years. There's a small group of us in the United States who are urging caution, and there are many people who are part of these constituencies, including parents of gender questioning kids, and then a small group of people who are increasingly vocal, who are called detransitioners, who are saying some of the practices to which they've been subjected are inadequate, if not horrifying. So I think for somebody to dismiss the concerns that many of us have internationally is really ridiculous, preposterous.
Yeah, I wanted to follow up with that. I feel like there's a more charitable read of some of the people who claim that there's a consensus on certain issues. So I think the charitable read of that is like, we know that dismissing people's, the kind of thing that happened in the past with prior, the way that you described having your transition treated at some point, that's not the right way to do it. There is some consensus in the field about a variety of things, not everything, but a variety of things. So I'm wondering if you could speak to what are the things we absolutely know, yourself as well as many people in the field kind of have come together and said, sure, we may disagree on the details here and there, but we all agree that conversion therapy is not good. Or, well, can you speak to those agreements?
Echoing your comment. So conversion therapy is not good. Doesn't help anybody, has harmed a lot of people. There's broad consensus that trans people are existing and always have. There's broad consensus that it's a small proportion of the population, but controversy over who is in that population and who isn't. I've been talking about the difference between the large group of gender questioning young people and a smaller subset of people who would meet criteria for transgender and would be enduringly trans. There's a broad consensus that intervention with the smaller, carefully screened group of trans people, that those folks benefit from gender affirming care and do better. And in fact, in the outcome studies historically, more done in the Netherlands than anywhere else, some in Sweden and in the US, that for the person who qualifies, who is enduringly trans, they do well if they receive support. And that support may include, in individual cases, medicines and even surgeries. So there's broad consensus about that. So you don't hear me say, although some have accused me of saying I don't believe in transgender healthcare, or that I don't believe in transgender affirmative healthcare for minors, or even up to age 25. That's a myth that's gotten passed around because I raised questions about what happens with young adults who present at gender clinics. So I think there's broad consensus about those things. The nuance is, how do we figure out who's going to benefit, who really is likely to be enduringly trans, because that's now become an enjoined issue. Some would say it's none of our concern to worry about who might persist in a trans identity. And I think that's also irresponsible, in that, if we have recommended and then provided gender affirming care, which includes medicines or even surgeries that produce irreversible consequences, I don't think we can be so cavalier as to say, well, you can just change that later. I think we have to own the responsibility for our recommendations and our treatments. And that's where we get into the weeds a little bit.
So As I mentioned in the intro, you are a former board member of WPATH and former president of USPATH, and you resigned a year or two ago from both organizations. And I believe this primarily stemmed from the fact that you were engaging in what you feel is responsible public engagement, but these professional organizations didn't see it that way and called for a moratorium on public discussions in mainstream media. Am I correct that this is what you saw as a problem and prompted you to move away from those organizations?
Yes, that's the principal problem. Is others said we shouldn't be talking to journalists, and I said that's preposterous. We're coming out with a new set of standards of care, and we want their support. We want to be communicating with the public, and we have to do that through media and journalists. And I couldn't see that as a proper strategy for the organization. So I said, if that's really what you want to do, you don't have my support. I'm gone.
Right. And I just want to clarify what this, there was a statement that was released by WPATH, I think following up some statements maybe that you made or some other researchers involved with WPATH, saying basically there is a robust debate within the academic literature, at academic conferences, in academic papers, but we should not have that debate in front of the public eye, was kind of the distinction that they made. And so I want to try to steelman this position, and I want to talk through it with you a little bit, because I think there's interesting ethical considerations here. So there is this like draconian move by conservative lawmakers to undermine healthcare access to this marginalized groups of trans people. We were talking about the consensus, like in the field. There are several consensuses that on different treatment options that we need to affirm identities in the sense that maybe not with medical care right away. There's some debate about when exactly to do that, but we should have an open mind and treat people with respect and that kind of thing. And you have just the entire Republican apparatus working very hard against that agenda, right? And so this is the context under which this kind of ethical argument is being made, that people need to communicate on this topic in the academic literature instead of in front of the press, because the press will take whatever we say and they'll strip it of its nuance and they'll use it to support an anti-trans legislative agenda or an anti-trans culture war. And so that seems to be the argument. What do you make of that?
I think that's a big assumption, that the press are going to use the anti-trans argument, or they're going to support the anti-trans argument. You see the controversy playing out in major media. Major media 2 or 3 years ago were reluctant to even cover this issue. I've talked to many dozens of journalists over the last 5 years. And as recently as a year and a half or two ago, many of them thought this was too controversial a subject to take up, and we needed to avoid it, basically. And there was that controversy internally at some of the major media, including the New York Times, among others. And what I think has happened is a number of journalists have gotten far more sophisticated about the subject matter and have been talking with a variety of people so that they can come to understand more of the nuance, more of the stuff that's a bit more complicated. And that whereas in the past, the general consensus was, well, we shouldn't do anything that might hurt trans people. Okay, well, what hurts trans people is to pretend like there aren't any problems, and for the Republican legislatures to expose the problems and then say, look, because of this, these people are ideologically driven and can't be reasoned with, so we're just gonna eliminate this care. As someone at the New York Magazine observed, the backlash from the right wing arguably has to do with the ideologically driven arguments of the far left than it does a nuanced conversation about the issues at hand.
I find that to be an interesting argument. It kind of reminds me of the arguments that people make in electoral politics, that the reason why people don't support the left wing is because there's too much wokeness, rather than people just being right wing and voting for right wing candidates. Like, I find it troubling to like blame the left because people vote for Trump, which I feel like a lot of people do, and that argument is interesting to me. But I want to, like, if we're going to take this this argument from WPATH that you'll contribute to the further marginalization of trans people by having an academic debate in public because bad actors will strip the nuance out of the debate in order to justify further stigmatizing legislation, I think we should try to understand if there's any evidence for that. So I want to go through a couple different topics that have come up in the public consciousness and then are also showing up now in right-wing legislation. So one of them is ROGD, right? For the audience, is rapid onset gender dysphoria. This was coming from a methodologically flawed paper by Lisa Littman, where she creates this narrative about social contagion, or it's been turned into this narrative about social contagion. It leaked out of the academic environment, and now it's in like the popular press, most famously spread by Abigail Schreier's book, and then it is a very popular talking point in conservative podcasts, TV programs, and now it's actually found as justification for anti-trans bills, right? So they'll mention this like concept of social contagion in anti-trans bills, and they'll point to Lisa Littman's paper. Do you see how that, like, this introduction of this concept into the popular consciousness has just done harm in the sense that it's being used now to like cite and justify what is essentially anti-trans legislation that I know you don't support, but I'm just curious how you think about that. Is this not evidence of WPATH's like concern?
It's more complicated than that. Social contagion is not a concept I endorse, but peer influence is unassailable in terms of how teenagers conduct their lives. So that's an example of it's a little more complicated, okay? And there are various aspects of this that I think are akin to that, in that I challenge the assumption that right-wing people are motivated because of things that various of us say or write. I think they're motivated, period. They have an agenda. You read the Republican platforms and the things tossed around by some of the right-wing organizations. They give talking points to legislatures, and they're talking to each other. Do they seize upon ammunition that they think will help their cause? Of course they do. Anybody who's trying to further a cause would be inclined to do that. So I just think it's very complicated. And do I feel personally responsible for what the right wing is doing? No, I do not. I do not.
Yeah.
I mean, I've talked to many people. I'm one of the very few people who's gender affirming who will go on conservative media and talk to them. And, thank God I didn't ever have to go on and talk to Tucker Carlson when he was at Fox. I was dreading the day of getting that call and trying to decide would I do it or not. But I've talked to a number of people. I also talk to people across the political spectrum. And, I make it a point to do so. I'm a big advocate of civil discourse. I'm a big advocate of conversation, about nuance. That word appears often in things that I've written or spoken about. So unfortunately, I see things as more complicated. I have a really wide sweep in terms of my experience in this subject matter, of course. I am a clinical psychologist more than 40 years. I've studied gender issues. I've watched the development of WPATH. I've been a member of and leader in WPATH. I've been in academic environments. I've studied some of the issues with gender youth in particular. And there's been a lot of changes, in my 50 years of taking a look at all of this stuff. And, we went from a variety of morphing, I guess you'd say, in the diagnostic categories that constitute being trans. And we've moved from a presumed pathology on the part of those who are trans 30, 40 years ago to now even U.S. government documents saying there's no inherent pathology in a trans identity. And WHO, through the International Classification of Diseases, has moved gender incongruence, their term, out of psychiatry and into sexual health, denoting that it's a difference. It's an individual difference rather than a pathology. So
Do you like that move?
I do like that move. Yes, I do. And of course, Americans are so ethnocentric. What I hear when I comment, as I just did, about gender incongruence in ICD, people say, "Well, how are people going to get paid?" And and this is all back ass words. It's like, no. We don't diagnose in order to be paid. That's such an American abomination.
Right.
We diagnose because we want to understand and we want to accurately describe and we want to differentiate what is going on with this person from another. So, I mean, I'm old enough that I remember learning from psychologists early career who had never billed insurance, and they didn't give a shit whether the insurance company liked them, didn't like them. It's like, no, they were providing a service, a legitimate service that people would pay them for. We're now conflating, diagnostic categories and even procedural categories, CPT codes, for purposes of reimbursement, which is, again, a problem in the non-system in America. Sorry,
Totally. No, I feel like that tangent is something we could probably all agree on. I think Dylan and I both want a national healthcare system. That's what we need. We need just people to get the services they need, irrespective of what, some insurance company is going to get a payout or not. It just needs to be that people can get access to the care. I think we can all agree on that point. And I also just want to clarify, you said something earlier that you don't feel responsible for the kind of way that maybe right-wing actors might use your words or words of other researchers that you might work with or agree with or have similar opinions of. And I agree with that to some extent. I think I certainly wouldn't blame you for the right wing thing. It's the same argument or the same point I was making earlier. I'm not going to blame, Bernie Sanders because Trump voters voted for Trump, right? Trump voters vote for Trump because they like Trump. That's why they do it. And they're going to continue to do it. I guess the argument is more not that that any given person is responsible, but that you can provide a air of legitimacy that otherwise would not be there, right? So like conservative lawmakers have been saying since the dawn of time that like a man is a man, a woman is a woman. They'll kind of argue from tradition, right? But now what we're seeing in some of this legislation and some of the cases is that they'll cite specific scientists, people who work at WPATH, people who work with USPath, and who have like a talking point that they've stripped from the nuance. And then they'll cite, The Atlantic, or they'll cite WAPO and use that to give a sense of legitimacy. We're the actual ones who are actually doing real science over here on the conservative side of things, because the liberals are all, believing in nonsense about gender ideology. Just to give an example of this. So I just want to make clear to the audience, you have spoken out against the proposed bans of medical transition in red states like Texas. You've said that they're consistently and vehemently, you've called them ignorant, prejudicial. And just to give people a sense of what these laws do, the Texas law specifically that we'll have in the notes here makes it extremely difficult for healthcare providers to provide gender affirming care to transgender people of any age, or for insurance to cover that care. It also prevents insurers from providing health benefits that include gender affirming care, and prevents Medicaid, CHIP, and other publicly funded insurances from covering gender affirming care. And this Texas law is one of 538 bills across US just in 2023. 96 of them have failed to pass, but 50 of them did pass, including the Texas one, and 300 of them remain in the legislative pipeline. And they are justified using a set of arguments, right? One of these, not in the legislature, but in a judicial case, a conservative attorney general cited the public debate to make their case for protecting children, quote, against the rush of practitioners to supply vulnerable young people with life-altering drugs and procedures. But they cite other people who are making similar arguments. I'm just curious, like, how do you feel about that? Because I know you don't support this stuff, but then you get cited, and that must be very frustrating for you. But I'm curious how you feel about it.
It is frustrating, and it is frustrating. But and I'm sure you've read a lot of these things, but if you go back and read all the Reuters pieces in the last 6 months or so, one of the things they did was they actually surveyed gender clinics, I think 11 of them. And in most cases, the reporter actually went with the family to the gender clinics. And I have been saying for some time that I'm worried that too many gender clinics are giving short shrift to mental health evaluation. They went to the gender clinics and found that in the very first visit with a gender questioning young person, the clinic professionals were talking about hormones prior to any reasonable mental health evaluation. And they've published that. And so, I actually had a psychiatrist question, where are these clinics that talk about hormones the first visit? And Reuters has served it up for us. And, I have other colleagues who are much disturbed by the fact that this is happening often. And that in some cases, it's not even the gender clinics, it's individual medical providers who are embarking upon hormones very quickly, in my opinion, in many cases prematurely, if not inappropriately. And this is happening all over the country. I started saying this a couple of years ago, and people said, "Oh my God, that's not happening. That's just not happening." And including some of my colleagues at WPATH, and they were disturbed that I would call attention to it. And I'm saying to them, "Excuse me, give me a break. I'm endorsing our standards, but these people are not following them. Aren't you concerned about that?" And they were in complete denial. They said, "Oh, that's not happening."
Gotcha. Yeah, I'm very sure that is happening at some clinics. That and that's I don't know. I have a psychiatric disorder. I have been diagnosed. I've been given medication. My experience in that has been that some medical practitioners, psychiatrists are just very quick to prescribe a medication and get you out the door so they can get the next person in. That has been my experience with some people. And then other people are very thoughtful and very good practitioners. And so it seems like this is the story for all of psychiatric medicine, right? That some in gender affirming care is just another case, right? Where people are sometimes really good at it and sometimes they're not. I think one of the arguments that people make is the central tendency of gender affirming care is still lack of access. It's still excessive gatekeeping. And we have the other, it's like a bell curve, right? And the central tendency is gatekeeping, but you have some people who do a lot of really extensive gatekeeping. And then you have people on the other side of the distribution who hand out drugs too readily. And so I guess some people are worried that if we are really reacting to these outlier cases of people who hand out drugs too rapidly, we could do that in a way that would, again, the central tendency is still excessive gatekeeping. And so we really need to solve that problem as our main problem. And then we have this other auxiliary problem of excessive drug prescriptions and stuff. What do you think of that? Where do you think the central tendency is?
Well, the history of the standards is such that we've migrated to more flexibility, less gatekeeping, less evaluation from a lot of it, years ago. I've been subject to it. I understand what's involved, but to go from a lot of gatekeeping or evaluation, I don't like the word gatekeeping. That's a pejorative term, but from too much evaluation to too little is a problem. Read Time to Think, Hannah Barnes' new book about the GIDS clinic at Tavistock in the UK. That's what happened there. They started out endorsing a lot of evaluation for all the kids, and they got skimpier and skimpier over the years as the demand for care grew, and they had multiple issues. But that chronicles is, I think, going to be borne out in parallel in the United States.
Yeah, I'm reading Hannah Barnes's book now. It is quite fascinating. I'm not finished with it yet, but I think, to piggyback off Manny's frustration about these, right-wing bills in red states in America, I share both of your frustrations. Those are terrible. I also feel this frustration when I hear on the other side of this, what I would describe as misinformation, like what you're saying, the idea that at some clinics that kids and teens are going through these procedures, these medical treatments without comprehensive assessment. I mean, this is not a secret. Like, clinics are bragging about this. They're saying very publicly, we do not require psychotherapy in order to receive medical treatments. As long as you say, this is your identity, then we'll put you through that. And this is happening. I mean, I guess that's where that from what I understand, that is where the crux of the disagreement and the controversy is that some clinics, many clinics perhaps, are not following the WPATH standards of care. So maybe we should talk a little bit more of that. We've been using these terms like affirmative care, and I'm curious, what do you agree or disagree with the affirmative care model? And is there anything that you take issue with in the WPATH standards of care?
Well, it depends on what your definition of the affirmative care model is. I wrote the chapter on gender development in the book about gender affirming care a few years ago. So I'm an advocate of gender affirming care, which is to say, accept what kids say to us, not at face value, and self-attestation is not the basis for medical treatment. No more a basis for it than it is if a kid comes in and says, I have a tic, or I have, multiple personalities or whatever. The hallmark of clinical psychology and clinical medicine is individualized evaluation. And that's what the standards of care dictate. And if we are not doing that, if we're simply taking at face value whatever someone says to us, mind you, a child, who has been influenced by social media, where there are no shortage of hours and hours of videos telling kids, if you're uncomfortable with your body, maybe you're trans. Mind you, this is a young person with no medical training who may themselves be trans, some of whom who have been very popular as social influencers have gone on to detransition. So I just think that we've gone through, there are multiple factors here. It's a bit more complicated. We've just gone through a pandemic. Kids jumped online and consumed unbelievable amounts of social media. We have a phenomenon of things called social influencers, people with no bona fide credentials per se, except their own experience, who are preaching to other people for clicks and dollars, whatever it is they are preaching. And I see too often kids who have gotten ideas about their gender from basically social media, TikTok, YouTube, Instagram, Reddit, et cetera, and we have echo chambers of people who think that they're learning things. I guess they are, but are they objective? Are they the best things they could learn about themselves? I have grave questions.
Yeah. So just to follow up on that, I remember hearing in another interview that just reaffirming every single thing that a young person says is usually not how we do psychology and medicine. Like if a 12-year-old said, I don't want to go to school anymore, you wouldn't say, okay, well, if you don't identify as a student, then you don't have to go through school. Like we wouldn't normally say that. So I think,
and I've literally used that example many times.
And I think, the kind of work that you do, which is, it's so challenging because you don't want to make someone in that context feel invalidated. You want to affirm in the sense that you're giving psychological credence to their experiences, while at the same time practicing what any good clinician would do, which is to nudge and probe a little bit and say, well, what do you mean by that? And how have these ideas developed over in your mind? And adolescence to me seems like the time in which a lot of this is in the process of development. And that's why it seems to me that doing this kind of work is just qualitatively different with adolescents than it is with adults. With an adolescent, you're talking about something that is in flux, that is shaping as they're going through this. I mean, I remember it was the same for me as a teenager, and it is for most people in those years. It can be difficult. It can be a time of storm and stress, to quote some older psychologists, but it doesn't have to be that way, but it often is. So I think this is where we're coming from, and to treat young people as if they're exactly the same as adults, just smaller, seems like the wrong approach.
Thank you. That's exactly right. And those of us who are schooled in developmental psychology understand that how someone how a minor approaches subjects is going to be different than someone who's 10 or 15 years older and fully mature. That's exactly right. And uh, I am exasperated by people who do exactly what you said. They treat children as little adults. Child says X, oh, must be true. Uh, we and to go a little further in the historic literature with psychology, self-report has 100 years of literature behind it questioning the reliability of self-report. We even have psychological instruments with reliability and validity scales to check, is someone trying to be that's for adults, truthful or not, or objective or not. So I think it's a far more subtle issue. I think I'm afraid some of my medical colleagues have distilled down some of these things into overly simplistic notions. The idea that if a kid says they're trans, treat them as such. The problem with gender affirming care, if it goes to gender affirming medicines, is that there are very significant irreversible consequences. And that's not the same as if a child decides to go goth, or a child decides that they're going to adopt a certain a physical style or whatever. Those can be changed. But if you've taken hormones, cross-sex hormones in particular, some things are going to change, and you can't go back. And that's the stories we're hearing of detransitioners who, when they were teenagers, went down this road. Puberty blockers, certainly cross-sex hormones, and in many cases surgeries, and then sometime later, as they got more mature and more life experience, they thought, "What the hell did I do? This is a terrible mistake."
I'm so curious to know, so these are, I guess, people that we would sometimes call cisgender, but nonetheless experience gender dysphoria. What do we know that explains this? Like, how does someone who is not trans experience gender related dysphoria?
Well, again, it's somewhat complicated. I think there are some young people who seize upon the trans identity as a solution to their other problems. They may have co-occurring or coexisting issues, and they maybe have been told by other people or encouraged by other people to think that, and if they just change genders, those other problems will go away. There's no scientific evidence of that, to believe that if you just treat gender in isolation from all the other problems a kid has, that all the other problems are diminished or go away. We have no objective reason to believe that's true. I have lots of clinical experience that says it's not, where I've encountered a kid who went down that road. So that's part of the problem. Again, the current context is highly tainted by these factors we're talking about: social influence, peer influence, consumption of social media as a way to find out who they are. As we're both conceding, adolescence is a time of identity exploration. So of course, all aspects of identity are open for exploration. I've encountered a number of kids who have had serial changes in their labels that they've embraced for themselves, and gone through a variety of them over in some cases, short period of time. A year or two, they've gone from one identity to another. And also in the mix is a bit of conflation, as we all know, between sexual identity and gender identity. So while those of us in the field would say they're not the same, they aren't, sexual identity or attractions and gender identity. They're not orthogonal, to use our math. They're not completely independent, because if you think about it, kids explore who they are in lots of ways experientially. They explore who they are in terms of relationships and attractions. They explore who they are in terms of gender. And sometimes those are kind of interactive. And whereas, some of my colleagues would say, well, you don't need to know about sexual attractions or sexual experience. I'd say, au contraire, I want to know, does this kid, do they know their body? Are they uncomfortable with their body? Do they masturbate, for example? Have they had an intimate sexual relationship? Now, these are not exactly comfortable topics to discuss with a somewhat sensitive teenager, but I try to, because I think they're important. And so, the last chapter has not been written on how these things are related, but I think we need to explore further how they might be related in individual cases.
Right. I wanted to just talk a little bit about this. You talk about, I think it's gender explorative therapy as opposed to affirmative care. Are those two different models? And
to me, they're not opposed.
Yeah. But one suggests that you should like really take your time. The gender explorative model suggests that you really take your time, and so here's where I would love for you to disentangle this a little bit, because I think some people perceive the gender affirming model, the gender explorative model that you propose, as being not like affirmative care in some cases, right? Because you can tell somebody, well, I'm curious from your standpoint, some people read into what you're saying that you're giving clinicians the opportunity to say, actually, your identity is not valid. You're actually not trans, and I need to try to persuade you out of it.
I never say that.
I know you don't say that. I'm saying people say that. So I'm curious, is there an instance where, as a clinician, you would tell a patient, hey, like, it doesn't seem like you're actually trans?
No.
Okay. There's no circumstance where you might do that as a clinician.
We could say there's a continuum in psychotherapy tactics between coercion on one end and non-directive acceptance, complete acceptance, no evaluation on the other. Mm-hmm. I don't think it's helpful to do mutually exclusive categories. For example, I would say that some of my colleagues who are practicing what they think is gender affirming care are actually practicing conversion therapy on proto-gay kids. They're converting them to being cisgender trans.
I guess my reaction to that is, I don't know of any good and peer-reviewed evidence of that, but I understand the claim from a clinician standpoint that you feel like you've seen that before. I guess I would be cautious about applying like specific clinicians, individual experiences, because you'll have people all over the spectrum on that. Like some people see that, some people say they have never seen that, some people say they've seen the opposite. What we really need is like systematic investigations of these things to really understand what's going on. Just in terms of the systematic investigations that have been done, like, we know that regret is really low. There's old data about persistence or desistance. I think a 2013 study by Dr. Steensma that gets cited a lot as being this kind of 80%, most trans kids grow out of it, 80% of them do. This is kind of the claim that's been made. But if you look through the methods of that study, and I'll put it in the show notes for the audience, you find that it was basically like any kind of gender nonconforming behavior was coded as kind of trans, and then if you like grew out of that, you were coded as being detransition, setting aside that they like 40% of the sample they couldn't get back into contact with, and they just kind of labeled them all as detransitioned. And so there's this kind of misinformation around detransition, that it's a very high percentage of people who are trans end up not being trans. But the reality is that I don't
think it's a high percentage, but I think it's a higher percentage than has widely been believed. If you look at a paper that was done by Michael Irwig in the Endocrinology Journal online last year, he conceded that in the surveys that were done that involved endocrinology, that 30% of patients who were followed were lost to follow-up. And the loss to follow-up was defined by hadn't had an endocrinology appointment for 6 months, were no longer being seen by the endocrinologist, and they were no longer refilling prescriptions. So if you take that as a reasonable hypothesis that some of the studies, and he actually looked at, I forget the available studies, which are limited, albeit limited. But he said, we probably have underestimated the number of people who have detransitioned. Somebody who's transgender, who's been under care of an endocrinologist, has been having cross-sex hormones for a period of time, a couple of years, doesn't just disappear and not take their hormones, unless they're deciding that they don't want to be on hormones anymore, which then begs the question of, well, why would they decide that if they're trans?
Is this a study that has to do with, is it like a military personnel study?
No,
It's not that one. Okay.
It's Michael Irwig. I think it was June, Journal of Metabolic Disorders. Yeah, I've had a lot of discussion with colleagues, all disciplines, by the way. The surgeons who say, oh, very few people regret having surgery. What we have to remember is there are a lot of people who don't ever have surgery. Okay. So, if you say, well, only 1% of my surgery patients regret having the surgery, and that is a low percentage, and maybe that's correct. Everybody who gets to a gender affirming surgery has been vetted before by other people, usually an endocrinologist or a medical prescriber, and usually a psychologist. So they've been getting a lot of gender affirming care for quite some time. So they're kind of committed to the course, right? And then if you think about making a decision to have irreversible gender affirming surgery, that's a big decision. Okay, which I don't think anybody does lightly, including the teenagers for whom I'm worried that it may not be right. So I'm looking askance at my colleagues who are surgeons who are saying, look, the regret rate is lower than it is for other types of plastic surgery. That's all well and good, but large surveys now are showing that a significant proportion of people who are trans aren't getting surgeries.
Yeah, and just to follow up real quickly on Manny's point about the longitudinal studies on regret rate, it seems to me most of that data comes from adults, and we have very little, if any, long-term data on adolescent onset gender dysphoria. Like most of the research comes from adults, and a lot of the studies on the adolescent onset gender dysphoria patients or clients, they are short-term follow-ups. So, in a matter of months rather than a matter of, and we see in the detransition literature, most people detransition after a significant period of time, like 5 to 10 years. So that I think represents a genuine gap in our knowledge, unless I'm wrong, unless they're,
No, I think you're absolutely right. And the critique about using the traditional longitudinal studies from the Netherlands and so on, to point to how beneficial it is to get gender affirming care over a period of time is well and good, and I'm happy for it, except the current cohort of teenagers, as you imply, doesn't match the cohort of those who were studied in those follow-up studies.
Right.
There is a gap, as you say, a legitimate gap in our knowledge. And so I am concerned that people are relying upon the historic research for follow-up and for outcomes without recognizing the difference between the cohorts.
Yeah, and just to speak to the difference between the cohorts, because we also talked about this on our episode with Dr. McLammer. In the past, the kind of experience you had was growing up not knowing that transition was even a possibility, right? And then whenever you're thinking about transitioning, you are living in a culture where that's just not really an acceptable option for you, even if you think about the possibility, even if you start to see a psychiatrist. My understanding of the literature on detransition is that one of the primary drivers of detransition is not having a supportive environment. And so your friends and family don't actually accept you. You end up detransitioning back because you're not in a supportive environment, and that being a really strong predictor of detransitioning. So I think from my read of that means that the kids that are starting out transitioning at a younger age are going to do so into a more supportive environment, thereby getting rid of one of the big predictors of detransitioning. So I guess it's a hopeful future that the people that are transitioning now probably won't deal with the same challenges and struggles that a lot of the previous cohort would drive a lot of the previous cohort away from their transition.
One more question just to follow up, because we've been talking about what's going on in other countries. You mentioned the Netherlands and other countries in Europe, and how they're kind of switching or scaling back medical treatments for adolescents with gender dysphoria, citing poor quality evidence or what appears to be a lot of unanswered questions about the psychological profile of adolescents seeking to transition. So, and again, just to highlight what we were talking about before, it seems like in North America, you're getting a kind of different message. And I guess what do they know that we don't, or what do we know that they don't? Like, where is how can we explain the gap in the knowledge, the collective knowledge we have?
Well, the two are completely different. In Europe, they have national health authorities that can set policy. They have national health systems that pay for services, and they have nationally sanctioned clinics. In the U.S., we have a free-for-all. We have no uniformity. We have no national payer. We have no national policy system. And so the question is, and we have a for-profit healthcare system, bluntly. So, there's so many differences. It's very difficult to compare. I think, frankly, the Europeans, and I've said this as long as 2 years ago, frankly, I think the Europeans are far more objective than we are, calling for the evidence review based on concerns, emphasizing, as they have, for gender questioning kids, psychological support as the first line, and more rigorous evaluation as they have. I mean, I'm in dialogue with Hillary Cass. Okay. When you get to chapter 21, you'll see my name in Hannah Barnes' book. I'm talking to people in Europe. I'm meeting with them. I'm going to Europe in a few weeks. I'm going to be meeting with some of them. Okay. I think they're onto something. I think the combination of different cohort, lack of, gaps in research, low quality evidence applied to now a more heterogeneous group, raise questions. And so, it's time to think clearly about these things. And what I find so horrific is people who say, oh, don't think about that. You don't need to think about that. That's either not worth thinking about, or you're wrong, or whatever. It's like, are you a scientist? Do you actually want to know what's true? Well, let's talk about it. Let's try to figure it out. Let's try to learn what we can so we can do better. And in a long career as a psychologist, I mean, I try to be humble about what I know and what I don't know. And we start learning about individual patients without trying to do so without assumptions. I mean, we have our base of knowledge, and we're doing our differential diagnosis, and we're trying to gather information and all that. But I have no vested interest in anybody being trans or not being trans. I just want to help the people that I get a chance to help.
Right. I'm curious, just on the topic of European countries. I know if somebody were to look at the state of trans healthcare in the United States and draw a conclusion from that, saying that, man, there must be this like really vigorous academic debate about whether we should have trans healthcare or not, because so many states have blocked it, then I would say that's not the correct conclusion. What we have is a right-wing party that is pushing an anti-trans agenda, and that is the explanation for why there's this like debate. I'm curious to what extent, because I find this very hard to like search for stuff in Nordic countries or understand what's going on, because I can't search in their language and I can't read like really good coverage of the topic. All I read is like mostly right-wing outlets here. It's just the nature of American press, I guess, covering this shift in policy. But I'm curious, is there any kind of right-wing push against trans healthcare in those countries in the same way that there are here? I know they have far-right parties. I just don't know how much they are pushing legislators to change things or anything like that, the same way that's happening in the US. I know for sure it's happening in the UK. The UK is very much like an unfriendly place to trans folks in many ways. So I'm just curious, is that happening in France and in Sweden, these kinds of things?
Well, you have to take it country by country. I know very little about France. I know quite a bit about Sweden. I know quite a bit about the UK, and I'm going to learn a lot more about Finland. The report of the Swedish Health Authority is now available in English, and it's very well documented. I'm meeting with Michael Ledeen, who's the principal author, in a month, and I think they are trying to be as rigorous as they can while being as compassionate as they can. I mean, so I was on TV in Sweden some years ago. I don't know if that's come up in any of what learned about it. I was the first openly transgender person in primetime television in Sweden in 2016 on a very popular TV show there. As a consequence, I became a little bit, had a little bit of notoriety, and I had a chance to meet with people in the government, health authority, including ultimately the prime minister. At the time, the parliament was debating issues regarding trans. And to show you how different things are in Sweden than in the USA. So they had already abolished what had been mandatory sterilization, which still exists in most countries in Europe. If you want to get your services paid for, you have to agree to not have children and not save sperm and egg and whatever. But they were debating a reparations bill to pay those who had been harmed by involuntary sterilization. And I testified, as much as that would be what it was, to members of parliament and leaders in the government. That bill was passed, and there was some millions of kroner set aside, significant dollar figure, to pay the almost 900 people who were still alive who had been involuntarily sterilized. That would never happen in the US.
Right. No. And that's a fantastic story. Like, I'm glad that happened. Every time reparations actually works somewhere, I'm always just happy that it does, because that seems important.
And it belies the humane and progressive attitudes of Sweden. And yes, there are Swedish Democrats who are characterized by some as neo-Nazis. And yes, there's a very ultra-conservative element in Sweden. There were Nazi sympathizers in World War II. Sweden ostensibly was neutral, which it was not. I mean, it didn't declare war against Nazi Germany because they were selling munitions to Germany.
Right.
Dynamite was invented by Alfred Nobel. So it's like, it's a complicated story. And we have to remember that all of these things are happening in societies which have a history and a context. And it's just so sad that in America, things get politicized that shouldn't be. Providing humane care to a small group of people that need it. Why should that be an object of politicking? I think it's because it's a fringe issue which can be oversimplified very easily. And, people can make political capital out of it. And frankly, as those of us who watch this happen know, gay marriage was changed. Marriage for all was changed by a Supreme Court decision, as was the employment discrimination against trans people. But we're in danger of going backwards, frankly.
Yeah. And so this is a great opportunity to kind of pivot to policy. In terms of policy recommendations going forward, we're really curious what you suggest. How can we make a positive impact on policymakers to do what's best for young gender diverse people, but also adults? I mean, we have the current batch of legislation, mostly from the right wing, tries to eliminate or curb coverage for people of all ages in some cases. Mm-hmm. So I'm curious what kind of model you would like to see implemented.
As a start, I'd like people to actually know what the standards are, which most people, even those weighing in on the subject, don't know. I can't tell you how many providers I've interacted with in the last 5 or 6 years. I say they want to write a letter of support for a kid for hormones. And I say, okay, here's what should be in it. And do you know the WPATH standards? And they say sometimes, what's WPATH? They not only don't know the standards, they don't know standards exist. So let's start there. I've been haranguing this for a long time. Let's start with you actually getting educated about what the standards are and what the basis for those standards are. And then let's agree that this is not purely a psychological issue. It's not purely a medical issue. It's an interdisciplinary issue. So we should have all the disciplines involved. And that's not happening in the United States. There are, medical providers, physicians and nurse practitioners who eschew mental health evaluation, just prescribe the hormones. I think that's a travesty, and I think, I've called it out in one publication. I called it sloppy, and frankly, I stand by that. I think it's sloppy to not know what the standards are, to presume and to give short shrift to a proper evaluation.
So maybe a solution is, I'm curious what you think about this, to just not allow clinics to operate unless they have adequate training and adequate knowledge of what the standards of care are and how to do comprehensive mental health assessments. Is that a solution that, or maybe there should be an incentive to get that training?
I think we need to talk it through. I don't think I have the perfect solution today. For 4 years, I've been a consultant to the Illinois Department of Corrections in the prisons, trying to help them become more humane in how they deal with transgender people incarcerated. And we put in place a whole series of approaches, checks and balances, opportunity for consultation. And one of the first things we did was we provided training for all the medical and mental health professionals throughout the system, basic training with which actually I arranged through WPATH, and we taught them WPATH standards. And that seems like a reasonable first step, is like, let's have some common understanding of what we're dealing with here, because there are so many misconceptions and frankly, it's a lot of prejudice. And in many states, Illinois is among them, it's almost like they're not one state. They're urban areas and other areas, and the level of understanding of these things varies tremendously. And so we have to bring the standard up of what people know and sensitize them, and then provide, in my opinion, consultation for those who are getting started, just as I was implying I do with the people who are trying to write a letter for affirmative care. Then I consult with them. I say, here are the things you have to cover. And really what you're wanting to do is tell the story of this person and why this care that you're recommending is indicated.
Yeah.
And individualize it for that person.
Right. I've heard you advocate for also, we need more access to therapy as part of transition. And I think in general, I'm very much on board with a lot of the things that you're suggesting. I do worry about the extent to which there's some difficult, it'll create more gatekeeping in certain scenarios than maybe would be ideal. But I think all of that's on the margins. And I think you can have an academic discussion about what we should do exactly. And I think all of that's fine. The thing I'm concerned about is, and I think it gets to Dylan's question, I just want to repeat this, but should we ban the care that doesn't meet the standards that you're setting? Or should we just incentivize getting those additional training, having that therapy?
I'd prefer to incentivize it.
Okay. That's what I'm curious about. Because I think some people will point to Dr. Erica Anderson says, we are not providing the adequate care. Therefore, we should stop. We should get rid of this until the standards are high. And that's not what you're saying. You don't support that kind of move.
No, it's like if you think about a parallel, which is maybe a bad parallel, but auto safety, is like, should we just decide that you have to meet 50 criteria day one when we are tuned into auto safety, and if you don't, you can't have a car. We did this over years,
right?
Seat belts, various safety provisions, airbags, blah blah blah. It took a long time for us to get to, I would say, modern and much more safe vehicles than we had when I was a child. A ton or two of steel, and people getting hurt. And we've seen the benefits of that in terms of fatalities from auto accidents. And I think there's a parallel there. Maybe you don't know this. I have a public health background, so I think about incidence and prevalence, and I think about the idea that you have responsibility for a population. So let's conceive of a way to support what that population needs in a reasonable way. We're in America, so of course the economics are relevant, but deriving best practices is not a simple thing. And I would hope that all of us would be committed to best practices. Even those who want to prohibit care to trans people, I will say emphatically, it's been my impression that there are some people who are promoting these bills in legislatures who are really bigots, and they just want to eliminate trans people from public life. I mean, you look at what happened with the legislator in Montana, who's first trans person. It's like, shut up.
Yeah. Call them a demon or something. I saw a video. Yeah.
Don't. I mean, we can't do that. And arguably, we're a complex society, so we have to have dialogue about these complicated subjects. Everything's a bit more complicated, to use your theme. And
love it.
And let's recognize that it is, that it's not a simple yes or no. I'm sometimes given to calling people out when they want to characterize something as this or that, and I say, well, that may be another false binary.
Gotcha. So
those aren't mutually exclusive.
Something else I've heard you comment on. I think I was listening to you on Blocked and Reported, Jesse Single, and y'all talked about like how appropriate is the informed consent model for people who are under the age of 18 or even after the age of 18 when it comes to gender affirming care. I think correct me if I'm wrong, I thought in the conversation heard you say you were a little skeptical of how we can apply the informed consent model, because if someone just comes in and says they're trans, the informed consent model says, okay, I will treat you as such, and even we will offer you medical care to validate that, because it's all based on an informed consent model. And our last guest certainly had that perspective as well on this topic. And I guess I kind of do too. I feel like cis people get the benefit of just saying, I want to get this surgery, breast enhancement surgery, and you, doctor, are going to give it to me because I understand the risks, I understand the benefits, and I'm agreeing to the surgery. Why should we treat trans people differently in the context of informed consent?
Well, I don't think we should, to be blunt.
Okay.
But what we have to recognize, again, it's a little more complicated. Young people are not as mature as more mature people. What do we do with that? Okay. So the provision we make in American society is minors have to have parental consent, because someone younger than 18, certainly younger children, don't have the capacity, I think, widely accepted. They don't have the capacity to make informed decisions about long-term consequences that are irreversible. So we assume that parents do so for their children. I'm a big believer in driving consensus in such decisions among all the people involved: parents, kids, providers, and so on. And if somebody has reservations, let's stop and talk about it. What are the reservations? And there are huge individual differences. I have some kids, for example, who see me as a psychologist, who are gender questioning. And when we talk about their parents' reservations, they say, oh yeah, I know, they're just looking out for me and we have to, talk to them and so on and so forth. And other kids who say, fuck them, I know what I want, don't you dare question me. It's like, oh, come on, like really? And then I wrote an editorial about this, which was widely read and often misquoted, about transitional age youth, 18 to 25. Arguably, we know that the brain doesn't fully develop until you're older, maybe 20s, maybe more, and you become more mature, your abstract thinking is more refined and so on and so forth, and you have more life experience. So I raised questions about what should we do with this age group? By law in the United States, once you're 18, you get to decide all these things, except right. you don't have all the full rights of an adult, which is an interesting contradiction. You can't
drink alcohol.
Can't
basically
drink alcohol.
Yeah.
Yeah, exactly. So what's with that? So we let kids drink alcohol. We don't let kids drink alcohol, but they can do life-changing surgeries at 18 or 19.
They can also fight in the military and die in a war across the country, across the world.
I think we're all screwed up, frankly, and we're not of one mind about this sort of thing, and we need to be. I think so. So, I think like a developmental person, it's like gradations of maturity. And so, you could have somebody who's 18 who's smart and very mature and is able to grasp abstract things very, very well. And then you have other people who are 19 and 20 and they're concrete thinkers. They're really not very mature. They're impulsive, so we have to draw lines, it's, we have to do it. But I think, so I've said on the informed consent model, I'm still supportive of the informed consent model for adults, by the way. But I said, okay, so does that mean that, we shouldn't recommend any psychological support for somebody who's a young adult just because they can get medicine without that? I still think a gender change, particularly if you're involving medical things, is highly consequential. There's very few things about human behavior that are as dramatic as a gender change. And so, I think it's helpful for people to have psychotherapy. The people who are, young adults who come to see me do so voluntarily. I don't want to deal with somebody who doesn't want to see me, but I think they would appreciate the fact that, it's helpful. And the European authorities emphasize that. They emphasize psychological support as first-line intervention for all gender questioning youth. It's so sensible. When I get out of the echo chambers of people that I sometimes talk to with, not with you, but I tell them what I'm in favor of, and they think, well, that's so sensible. Evaluation, caution, support, consensus among the people involved, not controversy, not conflict. Kids do well when they're supported by their families. I want every kid to be supported, whether they're gender questioning or cisgender or whatever. And, if there's conflict in the family, I want that addressed. No one should have to endure ongoing, intense conflict within their family.
Yeah, I think it makes sense to get the consensus from all the people that are involved. I think there's a bunch of medical professionals involved anytime a child is put on medication, or there should be, I guess, is your point. And at your clinic, that's how you do things. You have like a clinical endocrinologist, a psychiatrist, psychologist, like these various groups and the parents, and everybody's on board. That all sounds good to me. The question is, should you not, and we've already answered this question, but I just want to make it clear to the audience, you're not saying that you shouldn't be able to get care unless all of those criteria are met. You're just saying that would be best practice.
Yeah. Because we have such disparity in the United States. I mean, some places in the country, there's no gender clinic.
Right. So it was just making that a requirement would mean that millions of people now don't have access to healthcare because they just don't have somebody. They live in a rural town that doesn't have, they can't get that kind of care that would be best, but ultimately they can't get that access to. I'm curious, for an 18-year-old though, do you still feel like we need that consensus within, maybe not with parents because they're 18, but with everybody in the room should still all agree with this person?
Yes.
Right.
I do. I mean, if somebody who is responsible and is looking at things as carefully as they can has a concern, why would we not want to hear what that is? Okay. So, like I said 5 years ago in a publication, you may have read it. I said, in our clinic, I'm the naysayer. I'm the one who sometimes says, wait a minute, there's another factor here. Let's look at that. And I would say, without question, my colleagues with whom I have practiced have all respected that. And they're very happy to take the time to hear me out about some concern I may have. And that's how interdisciplinary care should work, is, we should all use our best talents and expertise to try to help an individual kid or family.
It's interesting though, because again, like if we make the comparison to cisgendered folks who want breast implants, or they want, some kind of essentially gender affirming care, right? Because for a cis woman, you just want bigger breasts that fits like your idea of what a woman looks like. We just don't have this idea in our heads that we need a team of people to all agree that they can get that care. And so how do you feel about this disparity we're setting up between trans people who are trying to get gender affirming care and cis people who are trying to get gender affirming care? Do you think we just need to up the ante about how we treat cis people also?
I do. I do. There's an awful lot of excessive, well, I don't know. I can't say, there's no data on this, excessive cosmetic surgery. But in the bariatric surgery field, it's assumed that someone would have a psychological evaluation and the surgeon would want to know what that is before they would consent to that life-altering surgery. So there are parallels in some other specialty areas.
But you don't feel like we are holding trans patients to a higher bar than we are cis people?
Society has always held trans people to a higher bar. The original gender affirming programs at university medical centers as a requirement had people subjected to all kinds of psychological evaluation and treatment. And they had to interview in these programs with panels, interdisciplinary panels, none of whom were transgender, at least in the early days. And the question was, is this person going to be able to pass in society as their affirmed gender? And if the answer was no, that person typically was denied access to the surgery. And these were primarily in that day trans women. Okay, I know some of them. Some of them are friends of mine, and they've schooled me about what it was actually like. So that's where things were then. Arguably, we're trying to figure out where things are now. So there's always been a higher standard. I mean, if you think about it, look at what's happened with these so-called bathroom bills. Some masculine-looking women have gotten called out when they've simply tried to use the women's room, as they always have, because the fear of some people, oh, that's a trans woman, so she shouldn't be in here. So the hypervigilance about expectations, I think, is unhelpful. And I would hope over time things would change. I will say, I hope for a time when gender nonconformity is not so unusual, and we don't even call it nonconformity; we call it individuality. and so you don't have to fit a mold, a gender stereotype, to whatever, do whatever, be in a certain profession, be in a sport, be in a certain kind of recreation, or ironically, I think there's been a resurgence of gender policing. We would have hoped, I guess some of us would have hoped a few years ago that was relaxing. People are more accepted for who they are, but apparently not. Apparently not. There's an awful lot of abuse hurled at trans people, particularly trans women, I happen to know. And it's really unfortunate, particularly since we've been around forever. Why? But there is prejudice in society, and it runs really deep.
Yeah. Well, we really appreciate you being with us. We have a final, just kind of like philosophical question we like to end the show on. So this last question is, imagine you're in another dimension and you're looking at a panel of dials that control human behavior of humans on Earth, right? And it can be, the dials control really small things like how often people pick flowers. And there are dials that control really big things like how often people support anti-trans legislation, for example. And you can only move one dial and you can change something about the way humans act on Earth. So it can be human behavior, it can be the way people think, it can be something about human nature. So the question is, you can kind of just conjure whatever dial you want and it'll end up in front of you. Do you move a dial? If so, which one, how much, and why?
So my dial would be acceptance of individual differences, and I would turn it way up.
Awesome. Yeah, like that.
Well, Dr. Anderson, you've been so generous with your time, and we thank you. I continue to be so impressed with your work, and I just want to support everything that you're doing going forward. Keep doing what you're doing. It's really making a positive impact, and thank you so much for joining us today. Thanks for listening. Join us next time on A Bit More Complicated. If you enjoyed the episode, please subscribe to our podcast, leave a friendly rating, and share with a friend. If you have a reaction you'd like to share with us, please find us on Twitter at abitmorepod or send an email to morecomplicatedpod@gmail.com.